Renal trauma. We have already discussed abdominal trauma under the trauma section, but then a few specific points regarding your renal trauma again over here. So renal trauma is usually part of your polytrauma and it occurs in around 5% of all your trauma cases. Now the pathognomic of your renal trauma is your hematuria, which can be either gross or your microscopic. Now the severity of renal trauma does not correlate with the degree of hematuria. So this is a general misconception that the more the hematuria, the more is the severity of renal trauma. So no, it does not. It does not has any correlation with your hematuria. The type and extent of injury is by your CECT scan of abdomen. So we have this image taken from your Bailey and Love. So if you look at your grade 1 renal trauma, you have a subcapsular hematoma. In grade 2, we have a laceration along with the hematoma. In grade 3, you have a laceration which is much more greater than compared to grade 2. So the cutoff is in grade 2 laceration less than 1 centimeter and laceration more than 1 centimeter. Then we have a subcapsular hematoma which is much more bigger in size compared to your grade 2. Then we have your grade 4. Now what are the key striking features? So you have your laceration extending into your calyceal system. There may be a renal artery or your vein injury. Arterial blood clot may be present from your endothelial injury, right? And then your grade 5, which is your avulsion of your hilum. So these are your few important points which will help you to differentiate the various grades of kidney trauma, and your detailed grading has been explained in your abdominal trauma section under your traumas. Now, what are your indications for your emergency surgery exploration? They usually include your expanding or your pulsatile retroperitoneal hematoma, a PUJ obstruction, a renal pedicle injury, and hemodynamic instability. Now, if there is a persistent urinary leak, what you would do is a percutaneous nephrostomy or an internal DJ stent placement. Now, the majority of the cases can be managed conservatively, and reimaging is usually done after 2 to 4 days in case if you have a falling hemoglobin level, a fever, or an expanding flank mass. Right. So these are your few important points that you need to remember regarding your renal trauma. The basic take-home message from this renal trauma discussion is that not all renal trauma is going to require surgery. Initially, you will definitely go for a conservative management. Now, for all sorts of renal trauma, please follow the basic guidelines of your blunt abdominal trauma and your penetrating abdominal trauma, which we have discussed, and your investigation of choice remains your contrast enhanced computerized tomography scan. Thank you.